So Tetralogy of Fallot is the set of lesions including the RVOT obstruction, VSD, rightward deviation of the aortic origin, that is called as overriding of aorta, and RV hypertrophy. This was first described by in 1671 and recognized as a Tetralogy of Fallot in 1888. It is one of the first and oldest recorded congenital heart defect, and it in the early attempts of its surgical correction led to innovation that we define as the modern heart surgery. So it is the basis of heart surgery and starting of cardiopulmonary bypass and intercardiac operation and repairs. It presents as 5 to 10% of all congenital heart defects, and it's one of the most common cyanotic congenital heart disease. The deoxygenated blood from the body enters the RA. At the same time, the oxygen-rich blood leaves the lungs to flow into the LA. Blood in the RA enters the RV through tricuspid valve, and at the same time, the blood flows from LA to LV through the mitral valve. Blood in the RV is pumped through the PA to the lungs. At the same time, LV pumps the blood out into the aorta to supply blood to the oxygen with oxygen-rich blood. As seen in Tetralogy of Fallot, the structure defect leads to circulation of oxygen-poor blood. The 4 lesions associated with Tetralogy of Fallot are thought to originate from the anterior leftward malalignment of the conal septum, which some call as monology of Fallot. The VSD in these patients tends to be large, of the malalignment type, and non-restrictive, anterior, and usually membranous, and almost always directly below the overriding aortic valve with the direct continuity between the aortic and tricuspid valve. The juxtaposition of the aorta causes the anterior or cephalad malalignment of the RVOT, which then combined with the usual presence of the septoparietal muscle bands in the infundibulum causes the subvalvular RVOT obstruction. This RVOT obstruction tends to be at the level of the infundibulum. The pulmonary valve is almost always abnormal in both size and morphology. The leaflets are frequently dysplastic, tethered, while the fusion can happen with bicuspid or bileaflet pulmonary valve is common. There are frequently supravalvular stenosis, further complicating the RVOT. Furthermore, the branch pulmonary artery stenosis is commonly found, and more commonly in the left than the right PA, and roughly 7% of the patients have pulmonary atresia. It is important to note that the RV hypertrophy worsens in the antenatal period, thus compounding the subvalvular pulmonary stenosis and increasing the right to left shunt. This phenomenon explains why many patients can present months or even years later after birth. Tetralogy of Fallot is associated with multiple additional cardiac lesions. A PFO is present in nearly all cases, which is right-sided, with right-sided aortic arch is 25%, additional VSD is 15%, ASD is 10%, and coronary artery anomalies is 5% are also found. The most common coronary artery anomaly is LAD to RCA, and the usual course of which is at risk by operation or by traversing the RVOT. The RCA may also originate from left coronary artery and across the RVOT. The genetic syndromes are present in nearly 20% of the patient, with DiGeorge syndrome being the most common at 32%, trisomy 21 is 15%, and vectoral is 14%. So the right ventricular hypertrophy is secondary to PA stenosis. It increases pressure on RV leads to right ventricular hypertrophy, transposition of the aorta, VSD, and pulmonary valve stenosis. So embryologically, there is destruction of the neuronal crest cells during the embryogenesis, and in laboratory setting, the destruction of these cells reproduce the result displays with certain cardiac malformation. The, the age at which symptoms develop and the severity of the symptoms are related to the degree of RV obstruction. The flow through VSD is bidirectional but the predominantly left to right with RVOT obstruction, so it is called as pink tetralogy, and predominantly right to left shunt with severe obstruction and varying degree of cyanosis. Complete or severe obstruction presents in the early neonatal period after the closure of the ductus arteriosus, while a more mild obstruction tends to present in infancy or childhood. Patients who present as children will often have adaptive changes to the hypoxia, including polycythemia, digital clubbing, and they will squat or Valsalva to increase the systemic vascular resistance and thus increasing the pulmonary circulation. The polycythemia may lead to cerebrovascular accident, peripheral thrombosis, hemoptysis, and enlarged bronchial arteries. So-called as status spells as episodes intense the cyanosis, precipitation, and dehydration and upper respiratory infections, crying, straining, physical stress, or feeding can lead to loss of consciousness. While tetralogy of Fallot is typically diagnosed before the onset of these status spells in the developed world, and the presence of these episodes is an indication for prompt surgical repair. The clinical presentation is directly related to degree of pulmonary stenosis. The severe the stenosis results in immediate cyanosis following birth. Mild stenosis will not present until later. Growth is retarded due to insufficient oxygen and requirement, and there is shortness of breath on exertion. And in the status spells, the child can become cyanotic and may experience syncope. Echocardiography is the standard diagnosis where several clinical findings can guide the clinician. The auscultation in the mid-systolic ejection murmur can be appreciated at the childhood third intercostal space that radiates to the axilla and is associated with a single loud S2. Murmur tends to be softened and disappear during the status spells due to the lack of the flow through the RVOT. Because of the large size of VSD, there is often VSD murmur appreciated. EKG will show progressive RV hypertrophy, and chest X-ray will show a characteristic boot-shaped heart due to RV hypertrophy and oligemic lung field. Echocardiography will demonstrate the characteristic lesion and can guide the surgical planning and delineating the coronary artery branching patterns and the presence of additional cardiac malformations. In the rare instances, the cardiac catheterization will be required to clarify the anatomy. The surgical repair, in the surgical repair, the timing is very important. If the patient are asymptomatic and can maintain the oxygen saturation of greater than 80%, the adequate growth repair may be delayed 4 to 6 months. Classically, the surgical intervention should be pursued immediately after the patient's first cyanotic status spell. There is no medical therapy for tetralogy of Fallot. During the status spells, the care is primarily supportive and supplemental oxygen, intravenous fluid, and the use of intravenous phenylephrine to increase the systemic afterload and to improve the pulmonary circulation. Patients with significant neonatal cyanosis are typically given PGE intravenously to maintain the patency of the ductus arteriosus, but this therapy is ineffective after first few weeks of life. There are two overall strategies for the initial surgical management of tetralogy, including early complete repair or the stage approach. The complete repair is performed through the sternotomy on the full cardiopulmonary bypass, and after the aortic cross clamp is applied, the combination of the right atriotomy and the pulmonary arteriotomy and the RV infundibulectomy are usually performed to allow visualization of the VSD. Pulmonary valve and RVOT are carefully resected with subvalvular muscular bands, and the VSD is closed with a patch in either interrupted or running fashion. The management of this stenotic or hypoplastic pulmonary valve during the complete repair is the area of significant controversy and recent evolution of the approach. In these cases, the pulmonic valve is small, and the traditional approach includes the extension of the pulmonary arteriotomy into the right infundibulotomy following the transannular patch augmentation, while the technique gives the RVOT obstruction and patients are usually left with free pulmonic insufficiency. And this condition is tolerated in short term but leads to the RV dilation, arrhythmias, exercise tolerance, and the risk of sudden death requiring the pulmonary valve replacement later in the life. Multiple approaches to preserve the pulmonary valve competency have been proposed. The pulmonary cusp patch reconstruction involves the use of a single cusp constructed from the native or bovine pericardium, extracellular matrix, or the pulmonary homograft attached to the transcellular patch. Cooptation between the monocusp and the native valve leaflets may restore the valve competence, although the long-term durability remains of concern. Other valve-sparing approaches avoid the transalveolar incision to perform the valve commissurotomy to increase the coaptation area, followed by either rigid or balloon pulmonary valve dilation. This approach should be reserved for the patients with only moderate pulmonary stenosis, as it does not adequately relieve the severe RVOT obstruction. And in the subset of the patient, the pulmonary atresia or the coronary artery crossing the RV infundibulum, the homograft RV to PA conduit generally requires to establish the PA continuity. The complete repair may be performed early in the neonatal period. Some institutions favor the stage approach, including the early palliative interaction followed by the later complete repair. This approach may be particularly beneficial in the neonates with complex non-cardiac lesions, and a modified Blalock-Taussig shunt is usually palliative operation of choice, although the interventional approaches as balloon pulmonary valvuloplasty, stenting of the ductus arteriosus, and RVOT may also be utilized. Postponement of the stage procedure cites a shorter hospital stay and pulmonary artery growth and higher probability of avoiding the transannular patch during the later repair. By contrast, the potential advantage of early complete repair includes avoiding the deleterious effects of the prolonged cyanosis and the second major operation in the first year of life. In this case, the pacemaker wires are placed temporarily because of the potential postoperative ventricular arrhythmias. Individual chamber pressures are then measured before the chest is closed, and the pressure reading help to determine how effective the surgery was. And the complications are infective bacterial endocarditis, pulmonic regurgitations, arrhythmia, right ventricular branch block, and left anterior hemiblock. So this is a repair outcome. The new method for patching the VSD, the transcatheter patches were selected specifically for the VSD size. Radio-opaque loop wire is placed inside the patch, allowed for the attachment of the double nylon thread, and made at the retrieval of the possible necessary. The patient were anticoagulated with heparin initially, followed by ASA 24 hours later. 48 hours later, the apparatus was inserted into the femoral vein, where it was catheterized until it reaches the ascending aorta. Echo was used to determine its location within the heart and allowing for the proper placement of the patch for the VSD. Tetralogy of Fallot repair is usually fairly well tolerated operation. Transient RV dysfunction is not common secondary to the RV ventriculotomy and preceding period of the RVOT obstruction. The junctional ectopic tachycardia is most common post-operative arrhythmia, and overall mortality is quite low, with a greater than 99% of the patients surviving to discharge, and though the first year of life and greater than 92% of survival in 30 years. With the majority of the patients surviving into the teen age, the long-term monitoring and timing of the reintervention have become critical. Both supravalvular and the ventricular arrhythmias are increasingly common as tetralogy of Fallot patients grow older at the risk of the sudden death. Progressive RV dilation and dysfunction of the pulmonary insufficiency are the primary concerns after tetralogy of Fallot repair, particularly in the patients with prior transannular patch repair. Patients should be followed with a serial echocardiography and the magnetic resonance imaging. Pulmonary valve replacement should be pursued at the first signs of RV dilation, or if any heart failure symptoms are present, the reoperative PVR is traditionally performed via sternotomy, although minimally invasive thoracotomy approach have been proposed in the older patient. The transcatheter pulmonary valve replacement has been utilized as less invasive technique in these patients. However, the irregular nature of the RVOT makes this approach technically challenging in most circumstances. Thank you very much. Hope you have liked the videos. If you have any comments, then let us know. Thank you.